Buenos dias. Good morning, everyone. It's really a pleasure for me to be able to contribute to your World AIDS Day event. And I really thank the organizers for inviting me to share some updates on pediatric HIV treatment and prevention, and what are the new elements that we can share with you in 2021, which we know has been a difficult year, but one that has really still given us the opportunity to generate more work to support countries and tackle the HIV epidemic in children. So in my presentation, I will go over three key aspects. I will provide some updates from the 2021 consolidated guidelines. I will zoom in on two topics that we know are particularly difficult for the pediatric population, one being infant testing and the other one postnatal prophylaxis. And then I'll share with you some reflections as well as some updates on the tools that we are available to support in-country implementation, as well as some of the tools that we hope will have available in the future to treat children living with HIV in a better way. So, of course, typically in World AIDS Day presentations, we include global estimates. And I'm not going to do that today because I'm going to focus and zoom in on some of the content related to the policies. But unfortunately, you all are aware very much of how there's still progress to be made when it comes to preventing and treating HIV/AIDS in infants and children. And despite the great progress we've made, we know that there are still a number of urgent action that we as a global community need to take, of course, in a tailored manner compared to the epidemic context where we live in. So moving on to the updates from the 21 consolidated guidelines, which they really bring together a number of different recommendations for various years and also include some new components. And one that I certainly want to emphasize is how these guidelines strengthen the optimization of HIV treatment and prevention for infants and children. And in these guidelines, we really have stronger language on the use of dolutegravir as an anchor drug for first and second line ART. We also provide new guidance on regimens and dose adjustment for rifampicin-based TB co-treatment. For example, for dolutegravir, we confirm the same approach that, as you know, is being adopted for adults, which is to use dolutegravir twice daily from the start until the 2 weeks post-completion of rifampicin. We've also included important guidance on the transition to dolutegravir in children that are established on first and second line. These transition guidance is particularly important for those that are still on an NRTI-based regimen and those that might be on lopinavir/ritonavir but are in need of TB treatment, which we know is particularly challenging. For all of these children, viral load monitoring remains an important good practice. However, we do see viral load to be a tool to support clinical management, but it shouldn't be a precondition to transition to dolutegravir. And so for settings where viral load might not be available, we don't necessarily require viral load before transition to dolutegravir. The other component that I will explain a little bit further relates to the simplification of dosing for postnatal prophylaxis, but I'll get to that in a minute. We've also, in our guidelines, broadened the package of care for children living with HIV. For example, we have new recommendations on earlier initiation of ART in children starting TB treatment and diagnosed with HIV. And this is to align with existing and updated recommendation in adults. We're also capturing all of that as part of a broader package for advanced HIV disease, which is called Stop AIDS. This package was designed 2 years ago to be able to really implement advanced HIV disease interventions for children that live with HIV and adolescents too. We know that countries are making tremendous efforts in trying to tackle advanced HIV disease, certainly in your region too, and it's important that we do so by not forgetting the children. Our new recommendation also provides some nuance related to the implementation of cotrimoxazole in children that are exposed but uninfected. based on new recent evidence that points at the lack of clinical benefit of cotrimoxazole in preventing various morbidity and mortality causes in children that are HIV exposed but uninfected. We are in these guidelines providing the option for some countries that may have very low vertical transmission and very good EID coverage to be able to provide shorter cotrimoxazole administration for children that are HIV exposed but uninfected. And I would think that Argentina probably is one of the countries that may consider that. However, we don't have a lot of experience with this, so it will be important that as countries explore different strategies, they do document their work and share that with us so that we can consider it in our next iteration of guidelines. In these guidelines, we've also included an important section on pediatric non-communicable diseases. And this is really to acknowledge that children living with HIV don't just need antiretrovirals. They need screening, treatment, and prevention for non-communicable diseases that particularly affect them. That includes monitoring growth, neurocognitive development, and be able to assess and manage psychosocial and mental status. That's particularly important for the older kids and adolescents that we know do suffer from a lot of mental health conditions as a result of their vulnerability that comes with HIV. We also know that it would be important to screen for cardiac, lung, renal, and neurocognitive disease, and important to liaise with disability and rehabilitation services to really improve the quality of life of these children. And that links to the educational support that many of these children do require. But we know that if we change the beginning of the story, we change the old story. And so important to also remember how early childhood development interventions can really help children to change their trajectory for full development in the future. And so using the HIV program as a tool and an entry point for these type of interventions is going to be very, very important for the future. Other aspects of our guidelines do emphasize how service delivery needs to be differentiated according to the patients that we have in front of us, and re-emphasize and revalidate the recommendations that we already have for less frequent visits and less frequent pickup of medications. And that equally apply across populations, including children above 2 years, which is when we typically stop adjusting the dosing of ARVs. We also have new recommendation that really speaks about the interventions to ensure that we track people that may be lost to care and really facilitate their re-engagement in care. And finally, also, we open up for ERT initiation to be offered outside of the health facilities, acknowledging that certainly COVID times have pushed some of the health services outside of the health facility, and that many countries may wish to continue delivering services in that way once the restrictions are resolved and hopefully this pandemic is over. So now I'm going to zoom into a couple of aspects that specifically relate to infant testing and postnatal prophylaxis, which we know remain the sticky ones in many, many countries. So the first element I want to note is how when we think about HIV testing for children, we really need to think about a comprehensive approach for them. That starts with infant diagnosis, which obviously needs to happen at the right time with the appropriate action following the results, as well as confirmatory testing as a critical step to ensure that the results that we are acting upon are correct, and ensuring that we do get the final status of these children, because until a risk of transmission ends, we're not going to be able to have a final diagnosis in these children. And that's really important, particularly in the context of policies in many countries changing towards supporting breastfeeding for longer period of time. We also know that provider-initiated testing remains a critical tool to be able to identify children that present to the facility with when they're sick, particularly through malnutrition wards, TB wards, and inpatient wards. Now, we know that in the absence of the mother, these children need to have an age-appropriate test. We would typically test the mom to understand whether they're HIV exposed, but if the mom is not there, then again, we need to go straight to the age-appropriate test, which would be an RDT for children above 18 months and a virological test for children below 18 months. We also know that as the HIV epidemic evolves, index case family testing is going to be the most efficient way of identifying those children that may have been missed by the testing net in their at the beginning of life. And that means that every single time we have an adult in front of us that is living with HIV, what we should make sure we do is design their family tree, and that we test those kids at least once to make sure that they have not been exposed to HIV and not acquired it from their parents. Also, we know that in some settings where HIV prevalence reduces as a result of the great public health interventions that have been put in place, we know that streamlining testing approaches will be very critical. And that includes potentially using screening tools that will help us to be more efficient whenever we test children to identify those infected. Now, I want to zoom in even further on the infant diagnosis component, which we know it's often a difficult one to get. So the first message here is that infant diagnosis should really not be seen as a one-time event. This is a multi-step process, which is timely sensitive. And so we really have to make sure that that takes all our attention, and that children really gets the test at the right timing, and that results are returned rapidly so that we can act on those results. So the multi-virological testing algorithm that you see here is the one that WHO released in 2018 that really builds some work done in previous guidelines. And so there's nothing new here, but I just want to emphasize again how settings that might be able to provide birth testing may wish to do so, and be able to provide, also ensure that they have the capacity to provide treatment to very young neonates that we know are quite difficult to treat. But it's important that for those children that still remain negative after birth testing, that those kids are retested at 4 to 6 weeks with virological testing. We also emphasize the importance of having 9 months testing after a negative 4 to 6 weeks test, just really to provide an additional time for a window of opportunity for identifying these infants. And it's important we use virological testing because in some cases, these children may have already lost their maternal antibodies and may have not yet developed their own antibodies, which makes the interpretation of a negative RDT results difficult. And so important to ensure that even when we use the 9-month test, that it's a virological test. Again, obviously, every time an HIV exposed infant presents sick, needs to be tested. And we need to make sure that for all these tests we're talking about, virological tests we're talking about, an appropriate confirmatory test is undertaken, because we know, particularly in settings with low HIV prevalence like yours, the probability for that test to be falsely positive, it's quite considerable. So a confirmatory test is going to be important to make sure that we really are confident about that test results. One important new element that is in our guidelines is the recommendation around the use of point of care for infant testing. This recommendation was already in WHO guidelines, but it has been strengthened as a strong recommendation as a result of important evidence that was generated in multiple countries and showed that children that receive point of care infant testing were 8 times more likely to start treatment within 6 days, and that 92.8% of those started within 60 days. And clearly, this is really important when we know that mortality is so rapid in HIV, in infants living with HIV. And so really important recommendation. And you see here the 2 graphics that illustrate the evidence that we've gathered together to inform this recommendation. Now, we know that point of care for infant diagnosis might not yet be available everywhere. And so there's important implementation considerations that you see underneath the recommendation that really point at the importance of strengthening first of all, decentralizing ART, or strengthening referral systems for ART initiation, because of course, it's important that there is an action following the positive results straight away. We also know that it's important we continue to invest in the traditional lab-based infant diagnosis models, because we know the point of care might not be available everywhere, and we want to ensure that the standard approach is really the one that it's still quality assured and supported as needed. The other element I wanted to touch on today, just as a refresher, is that since 2016, WHO has recommended that in case of a confirmatory negative NAT, a third NAT should be reported before considering ART interruption. Now, you may remember that I stressed the fact that when we have a positive test result, we should get a confirmatory test result. It's important, however, that the confirmatory test results, the second one, would often become available once the child has already started ART. And so the interpretation of that third NAT, it can be challenging in many situations. So and so it's likely to be actually negative. So there's still a chance for that child to still be infected. And so it's very important that once we interrupt treatment based on that third virological testing, that we have very clear about what we should be doing. So first of all, interruption of treatment should only be recommended for situations where the child doesn't have signs and symptoms suggestive of HIV infection. And also a child that can be followed up, and there is a follow-up plan in place so that we don't lose contact with that child after treatment has been stopped. The introduction also of what we call the indeterminate range should potentially reduce the number of discordant tests that I'm describing here. However, we know that some countries have been implementing the indeterminate range in different ways, and so it's still an important concept to get through. So there are a number of factors that really were considered for follow-up of infants that are undergoing treatment interruption. The first one is that active follow-up to ensure a potentially infected children is retained, and reinitiation on treatment if virological rebound occurs. So as I mentioned, we need to have in place a follow-up plan. We know that typically virological rebound in HIV-infected infants starting ART early is expected to happen within 8 months of interruption in 99% of the cases. And so that's really a time point that we've considered in our standard operating procedure to manage these kids. Obviously, infants who develop signs and symptoms indicative of HIV infection should undergo immediate NAT testing to make sure that we identify that viral rebound as quickly as possible. Breastfeeding and continued risk of transmission, of course, require follow-up and appropriate testing throughout the period of risk until final diagnosis. And this is obviously to consider that complexity that is particular of populations where breastfeeding is the recommended policy throughout, according to standard practice. So in this slide, you can see a visual of the standard operating procedure for discordant results and when cessation of breastfeeding happened after completion of the follow-up post-ART interruption. And so you can see here very clearly NAT number 1, positive, NAT number 2, negative, NAT number 3, negative. At that point, stopping ART would be what we could do. And then you see through 8 months, important to repeat virological testing first after 4 weeks, then after 4 months, and then at the end of the 8 months period. Obviously, if cessation of breastfeeding happens after the completion of the follow-up, additional testing needs to be done once breastfeeding ends. The second type of standard operating procedure is for situations where we have a cessation breastfeeding before the completion of the follow-up, post-ART interruption. You see that it's largely the same. It's just that you don't do any further tests after the 8 months post-interruption. So hopefully this helps to manage some of the patients that I'm sure you might have come across in your own settings that really challenge the way we manage these kids. Now, the other element that is very important, particularly in settings where we're still trying to get to zero when it comes to vertical infection, is the toolbox that we have to prevent vertical HIV transmission. And there's obviously various interventions that relate to the mother. So how we provide combination prevention for pregnant lactating women, how we provide antenatal and postnatal maternal HIV testing, obviously adherence support, and service delivery model that really ensure that women continue to be adherent and engage in care. But we know that we have another element in the toolbox, which is postnatal prophylaxis. Now, we know that postnatal prophylaxis continue to remain important because women can still present late and during pregnancy. We know that there's been several studies that have suggested poor retention during pregnancy and breastfeeding and incomplete adherence, particularly as women go through these difficult times in pregnancy and the postnatal period. So WHO has, for a number of years now, recommended a risk-based approach that really design different strategies to provide postnatal prophylaxis based on the risk that that child may have to acquire HIV from the mother. And as you can see in this algorithm that we've designed, this is very much depending upon whether we know if the mother is, we know already if the mom is already infected and whether she's or not on ART. If she's not on ART, or if she's been recently identified, then of course those kids are at high risk. If the mother is on ART, then those kids typically would be at low risk unless we actually know that the mother has a detected viral load that is undertaken in the next within the 4 weeks prior to delivery or on delivery. And if, for example, we don't have a viral load, however, we know that the mother has been on ART for less than 4 weeks. So if the kids are defined as low risk, then the standard approach of using AZT or nevirapine for 6 weeks would be recommended. For every other case, we would then recommend what is called enhanced postnatal prophylaxis that you can see summarized here. And it's different, obviously, according to whether kids are formula fed or breastfed. If they're in both cases, enhanced postnatal prophylaxis would entail combining AZT and nevirapine for 6 weeks. And if the kids are breastfed, then AZT, nevirapine, or nevirapine alone should continue for other 6 weeks so that we can ensure that the mother really reaches virological suppression through treatment. Now, we know that dosing these drugs in these babies can be very challenging. And so we've tried as much as possible to simplify some of the age-based ARV drug dosing for administering enhanced prophylaxis. And you can see here, not just dosing for nevirapine and AZT in syrup form, but also as core dispersible tablets. Now, one important addition of this in these guidelines is that in special circumstances with stockouts on nevirapine or AZT, and we know that's been observed in many countries during the pandemic, programs might wish to use, at least for a temporary, as a temporary solution, other drugs. And those include valtegravir with treatment dosing, 3TC, or lopinavir-ritonavir, based on the evidence that was gathered through the PROMISE-PEP trial, and we reported exact dosing to be used under this table. So important addition that, again, I want to recommend, it's really time is a temporary measure in those situations where you don't have nevirapine or AZT available. Now, moving on to the tools that support implementation, I want to note how over the last year, we provided a number of new additions to what we call the AIDS-Free Toolkit, where there is a lot of tools that hopefully are helpful for people in countries. And I would recommend you to go on the WHO website and look for these toolkits. That is very useful. And last year, we added, for example, the ARV optimal formulary that reminds us what are the key and minimum set of formulations that needs to be available in a given country. How we introduced those new formulations through an additional brief that was released in July, and then how we dose these drugs through a dosing annex that is available within WHO guidelines. And that is obviously of great importance for those of you that manage these kits directly. Now, related to that, I also wanted to share with you that in a couple of days, we'll be able to release a very exciting piece of work, which is this dosing dashboard that the Pediatric ARV working group has developed with support of WHO, and that will allow all of you to have access to dosing information in a very dynamic and user-friendly way, but also to have access to any type of update that may occur and that the Pediatric ARV working group may wish to do as a result of any new piece of evidence or work that might occur over the years. So really an important dynamic resource that we hope will be available to many of you on the ground. We also adding this new policy brief that I want to note, it's quite important because it helps us to think about the interventions that we provide to infants and young children in a very holistic manner and in a comprehensive way through a comprehensive package. And you can see here just this visual that summarizes some of those key interventions. And so we hope that this policy brief will really help those of you that are engaged with designing programs and delivering this care in many settings to really not forget any component of the package and be able to provide it in a more integrated manner. But the other thing I wanted to talk a little bit about is how we think about the future and how we enable better pediatric formulation to become available for children, particularly as the ARV pipelines continue to evolve quite rapidly for the adult population. And so many of you might have seen this list before. This is called the PADO list, and it's a list that we've often used to really identify what are the key priority products to be developed and investigated. And over years, you can see that we have listed a number of products that were in the short list, so in the 5 years time horizon, and then a long-term list that would go more into a 10 years time horizon. And as you can see from this list has been changing over time, of course, as evidence has become available, as products have become available, but also as perhaps difficult decisions were taken to be able to streamline this list and provide a more targeted approach to drug optimization. And so some of the drugs like dolutegravir that were identified in the long term by the PADO list graduated over time into the priority list for then being actually developed in 2020. And as you all know, now dolutegravir 10 milligram dispersible tablets has gained regulatory approval and is therefore becoming increasingly available in countries. And that's very much a success of a lot of collaborative efforts that have been put in place by many, many stakeholders. So in this most recent edition of PADO, which happened between September and October, we have tried to really look at the future and think about the new classes of drug that will become available. Think about how we also consider monoclonals as a new way of, as a new tool to prevent and treat HIV, how we can think about pediatric technologies as a way to better deliver the drugs that we have available, and also how we bridge constantly treatment and prevention. And not just that, but also think about the baby and the mom together, because we know that the maternal ART can have an influence on what we use for prevention and treatment of HIV in those babies. We're also aware that a lot of these new elements that really takes us into the new era of ARV will require new methodologies for investigation, and perhaps using more real-world data that are generated by programs. And I think that ultimately what we want to do is more and more think about drug optimization in the context of the service delivery model that we have in place and how we anticipate the HIV program to change over time. This year, we also made an important effort to try to be more systematic and explicit about how we prioritize drugs and formulations. And this is the result of a survey that we undertook with a broad set of stakeholders to identify what are the key drivers of prioritization for ARVs in children. And obviously, efficacy and safety are the key one. However, I want to point out how drug acceptability for the patient and also ease of administration and the feasibility and acceptability for the program are critical considerations that needs to be taken into account as we prioritize. And this is work we undertook in collaboration with CHI that has led a lot of this work. And we're very happy that we have this additional piece for PADO this year. One other element that is fairly new, it's a closer look at the new technologies, and in particular as more emphasis is put on long-acting administration of drugs for adults. And I'm sure many of you are really excited by the idea of potentially having long-acting drugs for our patients. But what about children? How should we deliver those drugs? And so we looked at some of the technologies across the age spectrum of children and adolescents. And without going into the details of this table, we, for example, noted how thinking about microarray patches might be quite difficult for a population of adolescents because the size of these patches might need to be quite big. In the contrary, for adolescents, it might be quite attractive to have an implant that can provide also contraception at the same time. So important differences according to the population you are considering. When it comes to injections, we observed that probably subcutaneous injection would be very well accepted across the age spectrum, and intramuscular potentially as well. However, that will depend very much by the volume and the site of administration, which of course might be quite difficult for neonates and infants. So one other element we discussed was to try to match some of these characteristics with some of the compounds that we know are coming through the pipeline. And we started to do this matching a little bit. And you can see how for new drugs like lenacapavir and islatravir, we may actually have multiple options for formulations that will allow long-acting administration. So really a lot of work that needs to be done in collaboration with the innovators that are leading these clinical development programs. In our work at PADO, we also noted how neonates remain a very vulnerable population, how we still have a data gap, particularly when it comes to preterm and low birth weight neonates. And that is still important as we start to approach these new ARVs and how, we really need to think about how we need to anticipate some of that research for the new molecules and new drugs that we really hope to get to children as quickly as possible, both for the purpose of treatment and for the purpose of prevention. Now, the discussion at PADO 5 led us to come to a list that you can see here in this slide that includes 5 formulations. We have 3 that were already in the previous list, which are abacavir, lamivudine, dolutegravir, 60-35 milligram, darunavir, ritonavir fixed dose combination with 120-20 milligram, and then TAF containing formulation either as a dual or as a triple in combination with dolutegravir. But the 2 key additions this year are islatravir oral and CAB-LA, long-acting. And both additions are really reflecting a shift that we are having in thinking about postnatal prophylaxis and how some of these drugs could be really transformational for providing postnatal prophylaxis to infants. Now, for the watch list, which again, it's for a longer time horizon, 5 to 10 years, the drugs that we have prioritized are lenacapavir, either single as oral or subcutaneous, or in combination with islatravir, again, as oral or as injectable. But there was certainly a lot of interest on the use of monoclonals and bNAbs. The problem is that at the moment, we do have some initial information about the PK of some of these bNAbs, but we still don't have the right cocktail to be used in infants. And so a lot of progress being made, and we think that this field is going really fast and certainly of interest for the pediatric population. And then, as I mentioned, the importance of thinking about new technologies, microarray patches as one that is very attractive, and the importance of test these technologies with the new drugs that are coming through the pipeline. Clearly, there's many research priorities, and we hope that many of you out there are going to be willing to contribute to some of this, to addressing some of these research priorities. I talked about preterm and neonatal dosing for existing and future ARVs as a key gap. Sequencing NRTI, many of you might be familiar with the Nadia trial that noted how dolutegravir remained very effective even with a partially active NRTI backbone, which we know is often the case for children, but we know that that type of study is not available for children yet, and so it's something important to document even in a programmatic context. Again, also important to continue our work in research for bNAbs and to really meet the defined target product profile and preferred product characteristics that we have designed for the population, and overall do more work on acceptability and feasibility of innovative technologies in the future. There's many more questions that are being summarized as we speak. We are writing a paper that we hope to share with many of you very soon, so that we can really give you more visibility about what are the key questions to answer. So let me now wrap up this presentation and really note how, you know, despite the important remaining gaps, as I mentioned, there are strong signals of change. And what we have to do at the moment is really globally sustain the effort and expand that effort on the ground. Also, we need to ensure there is continuous south-to-south learning and sharing and really new solutions that can be expanded. But also, as you know, we go through the COVID pandemic and we see our patient coming back to the facility, it's important we maximize that opportunity of providing care and all the interventions that we know they need that they might have missed during the pandemic. Clearly, WHO guidelines strengthen the existing recommendations that we have and add nuances that are quite important, that provide additional guidance to many of you, and that also helps us to expand the package of care for these children. We noted that we do have new tools that hopefully will support implementation, but there's also new potential drugs that are in the pipeline that we'd love to see be used in children. And for that, we really need to think about innovative approaches and to really accelerate the research that is needed to make sure that we can use those drugs in children very soon. At this time, I think that it's important we acknowledge that the focus needs to be on implementation. We have the tools that we need, and really now it's about delivering them in the right moment, in the right way, in a targeted, differentiated, and holistic manner. And so I will close with that, but I really want to thank you all for, again, inviting me to contribute to your World AIDS Day event, and really want to share my encouragement and to the work that you are doing. I know many of you are very heavily committed to providing care to these children out there, and we know it's not always easy. And so we at WHO are very committed to be there to receive any of the core questions that you have, understand where are places where we might need some additional policies. And also, we know that when it comes to the pediatric HIV epidemic, we often look at the region of the world that is accountable for the largest proportion of these infections. However, we do know that there are regions like the one you are that equally have challenges, and even though they might be different challenges. And I think that we would really appreciate engaging with you further to try to understand what are the specific challenges that you are facing in your region. And we know that our colleagues in PAHO are very present and very much available to support you directly. And we would, we're very committed to be able to work with them to ensure that that happens in the most effective way. So again, thank you for letting me contribute to your day, and yeah, and good luck to all the work that you're already doing. Bye, everyone.